Good evening, everyone. I am Professor Paramjyothi here from Nizam's Institute of Medical Sciences, Hyderabad. And today we are going to have a very detailed, thorough, updated information on a very rare genetic disorder called primary ciliary dyskinesias. And the organizers, Dr. Krishna, Dr. Chennam Chetty, they have rightly chosen this topic because October is the month of PCD awareness month. So this PCD awareness month is done by patient or organization groups and researchers and PCD advocacy groups. And the aim is to increase the understanding of PCD, primary ciliary dyskinesias, promote timely diagnosis, support research, and improve patient access care. So those are the aims of the this observed by for observing this awareness month of primary ciliary dyskinesias. And as you are aware, PCD or primary ciliary dyskinesias is a rare genetic disorder, and it has more than 55 genes as opposed to say cystic fibrosis where there is only one single gene with of course 2000 mutations. Maybe they're in cystic fibrosis, but here so many genes are involved, more than 50, and every year I think new genes are being identified with the new technologies that are getting available to the researchers. And this is heterogeneous disease, genetically heterogeneous as well as clinical phenotypically. It is a very heterogeneous disease. And that's the reason why the diagnosis is little delayed. And there is one European study which showed that a patient has to see at least 55 times a physician before a proper diagnosis is made. So the delay in diagnosis possibly is because the awareness is less, or the diagnostic tools that are available, none of them are very specific to the diagnosis of PCD. And these equipments that are available these are very time consuming, very expensive machines. They need considerable resources and expertise, and they are very laborious. So all these things also contribute to delay in diagnosis of primary ciliary dyskinesias. Of course, it's a multi-system disease, so many specialities tend to see these patients, whether it is pediatrician or ENT or pulmonologist or infertility clinics or cardiologists for some time. So it's a multi-system disease. So it cannot go to a single specialty. They can go to multi-specialties. And according to the German bronchiectasis registry, in adult bronchiectasis, about 9% of them have primary ciliary dyskinesias diagnosed, as compared to other European countries or America. The 3% or 4% is the diagnosis of PCD in adult bronchiectasis. And if we go to the Embark India bronchiectasis data, I don't see PCD in the diagnosis of adult bronchiectasis. So that's the state of affairs of PCD in our country. And being a rare disease and being a PCD awareness month, it's very appropriate that we discuss PCD in and out today. And we have two speakers before we go to the actual panel discussion. We have two speakers. One is Dr. Nikhil Gupta, he's a radiologist, and we have Avishek Agrawal, a pediatrician. First, we'll listen to their talk and then go to the actual panel discussion. And I will introduce the panel discussion after we finish the lectures. So over to the presentation by Dr. Nikhil Gupta, a radiologist from Ludhiana.
So
I'm here to discuss about primary ciliary dyskinesia. Myself, Dr. Avishek Agrawal, MD Pediatrics, consultant in Ranchi, Jharkhand. First of all, I would like to thank Dr. Paramjyothi sir, the senior most pulmonologist in India. Dr. Atri Gangopadhyay gave me opportunity to represent in CCI. Dr. NH Krishnan, Chairman Founder of CCI and Whole Court Committee. So, what is primary ciliary dyskinesia? It is an autosomal recessive genetic condition in which microscopic cells in the respiratory system called cilia do not function normally. Ciliary dysfunction prevents the clearance of mucus from the lungs, paranasal sinuses, and ears, which will lead to accumulation of bacteria and irritants in the mucosa, causing respiratory infection and eventually bronchitis. PCD is a hidden burden with incidence of 1 in 10,000 to 20,000 per, often misdiagnosed as recurrent bronchitis or asthma. And in India, true prevalence is likely higher. So now we discuss pathophysiology of PCD. PCD, there is defective motile cilia leading to impaired mucociliary clearance, resulting in chronic sinopulmonary infection, otitis media, infertility, and situs abnormalities, resulting in accumulation of mucus, leading to chronic infection and airway remodeling, which eventually end up in bronchitis. So here in first picture, we can see the normal structure of cilia containing outer dynaenum, inner dynaenum, radial spoke, and central microtubule. While in picture C, in PCD patient, we can see here there is absence of outer and inner dynaenum. In second picture, we can see how normal cilia swept out the mucus from the airway. But in PCD patient, faulty cilia leading to mucus buildup. So, what is the genetic basis? Here, more than 50 gene identified like DNA H5, DNA I1, CCDC39, CCDC40, and more. And here we can see genotype phenotype variability. What does it mean? It means for different gene defect, there is different cilia abnormality and leading to different clinical presentation. So, how the PCD represent itself? In newborn, we can see unexplained respiratory distress in term infant, which is not actually classified from RDS or ATNB. Situs inversus, which is a part of Cartagena syndrome. In children, we can see chronic wet cough, recurrent pneumonia, bronchitis, chronic nasal discharge, otitis media with effusion, and gout filtering. In adult, we can see bronchitis, chronic sinusitis, infertility. In male, leading to sperm motility, or in female, leading to tubal dysfunction, which will cause ectopic pregnancy. So now the most important part is diagnostic tool. First, nasal nitric oxide. This is a screening test, non-invasive, and count lesser than 77 nanoliter per minute will give you idea about PCD. Second, high sensitivity video microscopy. This process dyskinesia or discoordination beating. Sample required here is fresh nasal or bronchial brushing. Then third investigation or diagnostic tool is transmission electron microscopy, which is gold standard for ultrastructural defect. However, normal TM does not exclude PCD and genetic testing. There are also some emerging and supportive tools like immunofluorescence staining, air liquid interference culture, functional rescue studies. So how could we proceed? Here, first we do clinical suspicion on the basis of detailed history and physical examination. Then we will go for a screening test, which is nasal nitric oxide test, followed by HSVM plus minus TM. If both of these were inconclusive, then we will go for genetic testing, or either we directly confirm PCD. Now, management principle. The worst part of PCD is there is no definitive cure yet in current era also, but airway clearance is the cornerstone therapy. Routine washing and suctioning of sinus cavities and ear canal is recommended with antibiotic treatment for infection and annual vaccination, which is very much important, of influenza and pneumococcal. So what we can see, this is a multidisciplinary care which includes pulmonologist, ENT, physiotherapist, fertility and genetic counseling, cardiology, neonatologist, and psychosocial support. So, many research has been going on, like gene therapy and ciliary regeneration trials, better genotype based diagnosis, registries, and AI assisted diagnosis. In India, we are facing some specific challenges like underdiagnosed and delayed diagnosis of PCD because of mistake, what it mimics like asthma, cystic fibrosis, or chronic sinusitis, limited access to nasal nitric oxide and genetic testing, lack of awareness among clinicians. We need a national PCD registry and regional lab. So, take home messages of today's slide is persistent weight cough is not always asthma. Must and always think about PCD. Early diagnosis prevent irreversible lung damage, and this is a multidisciplinary and family-centered management. Thank you. And now I would like to hand over to Dr. Nikhil Gupta, a radiologist, to elaborate us about radiology aspects of bronchiectasis.
Good evening, everyone. Before beginning, I would like to thank Dr. Krishna, Dr. Narayan Pradeep, and Dr. VK Chetty and entire CCI family for having me on board. I would now like to talk about radiology of bronchiectasis. I am Dr. Nikhil Gupta. I am a consultant radio diagnosis and imaging at Cilia Medical Center and Kuka Diagnostic Center, Ludhiana. The definition of bronchiectasis is irreversible dilatation of bronchial tree and is commonly accompanied by bronchial wall thickening and mucoid impaction. On chest radiograph, there are abnormalities are often seen but are very non-specific. Ring shadows are seen as end-on bronchi, as you can see here, and tram track opacities are seen as in-face dilated bronchi. Air fluid levels may indicate current infection, and peribronchial fibrosis may obscure the bronchovascular structures, as here. On CT, the direct signs are internal diameter is more than adjacent pulmonary artery, and there are contour abnormalities such as signet ring or tram track or string of pearl or cluster of cysts appearance accordingly. Here we can see a signet ring. Here we can see a tram track. And this is another case showing signet ring. There is lack of tapering more than 2 cm distal to bifurcation, and there is visibility of peripheral airways, which is touching the mediastinal pleura and within 1 cm of the costal pleura, as seen here. Indirect signs of on CT are bronchial wall thickening, that is about 0.5 into the diameter of adjacent pulmonary artery. Fluid or mucus-filled bronchus, mosaic perfusion, centrilobular nodules, as seen here, or trine bud appearance. And air trapping is seen in expiratory scans, as we can see here and here. What are the types of bronchiectasis? They may be cystic type or cylindrical type or varicose or varicoid type, or there may be traction bronchiectasis due to fibrosis. There are many scoring systems. The radiological scoring system is BRICS or bronchiectasis radiologically indexed CT score, and the clinical scoring system is bronchiectasis severity index or BSI. And there are other pediatric scoring systems, which is a mixture of both of these. So I'll be showing both of these quickly. The scores are 0, 1, 2, and 3 in all these. And there is bronchiectasis. The bronchus is larger than artery, as seen here. It is larger than the artery. And it is if it is 2 to 3 times larger, then it is grade 2. and more than 3 times is grade 3. Then there is peribronchovascular thickening, as seen here. Wall thickness is equal to artery. Wall thickness is 2 times the artery, and wall thickness is more than 2 times. Then third is generation of bronchi. Up to 4 generation bronchi are grade 1. Then more than up to 5th generation is grade 2, and more than 6th or more grade 3. So we add up these scores, and if it is more than 5, then it is severe bronchiectasis. Then the bronchiectasis severity index parameters are age, body mass index, FEV1, history of previous admission, exacerbations before study, MMRC dyspnea score, pseudomonas colonization, and colonization with other microorganisms, and also radiological severity. So this is clinical plus radiological score. Coming to bronchiectasis. So if there is bronchiectasis, it may be focal or diffuse. It may be in diffuse, it may be peripheral or central. So we will start from here. The central predominance is seen in ABPA, Munier-Kuhn syndrome, and William-Campbell syndrome. The peripheral predominance, upper lung predominance is seen in cystic fibrosis, sarcoidosis, post-radiation fibrosis. Lower lobe predominance is seen in idiopathic, post-infectious, repeated aspiration, fibrotic lung disease, post-transplant rejection, and hypogammaglobulinemia. And middle lobe predominance is seen in atypical mycobacterial infection and immotile cilia syndrome. Focal bronchiectasis is generally caused by congenital bronchial atresia, extrinsic compression, endobronchial malignancy, foreign body, bronchiolithiasis, and airway stenosis. This is a case of cystic fibrosis showing upper lobe predominance and volume loss. This is another case of adult onset cystic fibrosis showing cylindrical bronchiectasis and bronchiolitis. This is a case of sarcoidosis showing upper lobe involvement bilaterally with fibrotic changes. In India, we can't ignore this. So this is a case of tuberculosis showing traction bronchiectasis in upper lobe. Here on X-ray, we can see subtle tram tract opacities, which are seen as dilated bronchi here. And later, after treatment, the green bud nodules are mostly resolved, and the bronchiectasis is increased due to fibrosis. This is a case of post-radiation fibrosis in right paramediastinal location. This is also seen in upper lobe. Then this is a case of common variable immunodeficiency. Here we can see on X-ray multiple reticular opacities in bilateral pericardiac locations. Then there are some tram tract and cystic opacities. Here we can see on CT, there is varicoid and cystic bronchiectatic changes extensively. Then this is a case of rapidly progressing pneumonia, which developed ARDS, and there was residual bronchiectasis on a 5 month delayed scan. Here we can see a case of chronic aspiration. Lower lobes are involved. Here and here. This is a case of UIP pattern pneumonia. And as we all know, both lower lobes show cystic changes, that is honeycombing, and tractional bronchiectasis. This is a case of chronic atypical mycobacterial infection, that is MAC or MAI, Mycobacterium avium intercellular infection. And we can see both right middle lobe and lingula are involved. We can see bronchiectatic changes in both of these. Then this is a case of Cartagena syndrome. We can see dextrocardia, stomach bubble on the right side, and reticular opacities in bilateral lungs. Here we can see right middle lobe shows bronchiectatic changes, and the lingula shows bronchiolytic changes and multiple tree in bud opacities bilateral. And this is a case of allergic bronchopulmonary aspergillosis showing multiple hyperattenuating mucus plugs bilaterally. More generally more towards the upper lobes, but it is and it is in the central location. So this is a case of congenital tracheobronchomegaly or Munier-Kuhn syndrome. We can see an enlarged trachea and dilated bronchi. Main bronchi are also dilated, and most of the bronchi are dilated. Here we can see in the central location. This is another case of Williams-Campbell syndrome. Here there are bronchiectatic changes bilaterally, mostly symmetrically. Then this is a case of focal bronchiectasis due to a carcinoid seen here in the left main bronchus. And this is elevated dome of diaphragm and bronchiectatic changes in the left lower lobe. This is a case of asymmetric bronchiectasis in Swyer-James syndrome. The left lung is showing hypoattenuation with bronchiectatic changes almost extensively. What are the pitfalls in diagnosis of bronchiectasis? There may be cystic lung diseases like LCH, LAM, or Burt-Hogg-Dubé, or LIP. Then there may be emphysema, lung cysts, cavitary lesions, cystic lesions in PCP, reversible bronchiectasis in area of consolidation, and cystic mets. So thank you for your patient listening. World Bronchiectatic Day is on July 1st. Thank you.
Yeah, so that was great presentations by Dr. Avishek Agrawal and Dr. Nikhil Gupta. Thank you very much. And now we'll move to the panel discussion. We have a great panelist with us. We have Dr. Vikrant Ranga, adult pulmonologist from Haryana. We have Dr. Tribhuv Chatterjee, again, adult pulmonologist from Mumbai. Dr. Jayaprakash, pulmonologist, again from Trivandrum, Kerala. So I welcome you all panelists to this panel discussion on primary ciliary dyskinesias. I'm sure myself and the audience who are listening to this will be greatly enriched by your insights into this disease. Rare disease, though it's a rare disease, I'm sure you must be having a lot of updated information on this so that we all can get benefited. So we have Dr. Nikhil Gupta with us, a radiologist. He has presented to us about bronchiectasis in general. And because our topic is disease focused, primary ciliary dyskinesias, so we'll come to the PCD radiological diagnosis. But in general, if you have especially a younger child with recurrent respiratory infections, with or without bronchiectasis, what are the radiological findings that you would look for with reference to PCD? Of course, you may be having, you have already talked about cystic fibrosis, and you have already talked about primary immunodeficiencies also. But just to refresh our memory, can you just take us through the radiological features of primary ciliary dyskinesias?
Good evening, everyone. Thank you for such a wonderful question, sir. First of all, it is the young age of presentation, which is very important. Then the distribution of bronchiectasis in lung is generally middle lobe or lingula, or it may be in some cases towards the lower lobes also. And then there is a recurrent or persistent right middle lobe or lingular collapse, which can be seen. And there can be other abnormalities which are associated, like situs inversus and heterotexy, heart abnormalities like TGA, and there may be sinus abnormalities in primary ciliary dyskinesia, also known as Young syndrome. And then the bronchiectasis generally appears at a younger age, which I already mentioned, and maybe less focal than post-infectious disease. Then there may be additional findings like air trapping, early onset, and relatively symmetrical progression. And there is lack of scarring, which can be seen. And if we combine all these together with clinical findings, and we can reach to a diagnosis.
Thank you. Thank you, Dr. Nikhil. Now we'll go to Dr. Avishek Agrawal. Being a pediatrician, when do you suspect primary ciliary dyskinesia in children?
Thank you, sir. This is actually more practical question, and clinically what we see in day-to-day basis. First thing, sir, as you already told, it requires more than 70 visits to diagnose PCD. But definitely there are some red flag signs which we can see. And being a pediatrician, I would like to start it from neonatology time period. So in neonate, if in term baby and having unexplained respiratory distress, which require more than 48 hours of oxygen requirement, we should keep mind PCD in our mind and think about the DDs. Second thing is in X-ray, we would see X-ray should be normal, and there's sometimes presence of situs inversus or situs totalis, which is important. In infancy, three things to remember. One thing is chronic wet cough, which is not responding even to the antibiotic. Chronic sinusitis or rhinosinusitis means discharging nasal discharge was there continuous, and lateralis signs and symptom. In adult also, we have to see for till adult, we have seen number of bronchiectasis or patient are complaining I have a number episode of pneumonia or lung collapse in X-ray. So these are the red flag sign which we must keep in our mind before going to other DDs. PCD should be there. Thank you, sir.
I mean, do you use any clinical prediction tools? I mean, to further evaluate this patient for PCD?
Sir, actually, clinical prediction tool we must have watch only for the first thing is key. The symptom all itself demonstrate what are the cause and DDs was there. There are no any prediction tool which is I'm using right now, but definitely I would ask mother to the cough, the history of cough and the treatment already taken with a renowned doctor. Then I would definitely give her DDs in mind.
Okay. So thank you, Doctor.
Thank you, sir.
Now we'll move on to Dr. Vikrant Ranga. Yeah, Dr. Vikrant Ranga, can you tell us a little about ciliary function or dysfunctions, just congenital, genetic, and acquired, and non-PCD ciliopathies? If you can just give us an overview of this ciliary dysfunctions. Thank you.
First of all, thank you, sir, for the kind introduction, and I would like to thanks Dr. N.H. Krishna, sir, and N.S. Anil Maske, sir, and all the office bearer of CCI. So, regarding the question, like primary ciliary dyskinesia or secondary ciliary dyskinesia. So, primary, how to differentiate? How we can differentiate primary from the secondary ciliary dyskinesia. So, primary ciliary dyskinesia, we go by the history. Patient usually have started the symptoms at the early onset of phase, where the secondary, there must be some inciting agent like like infections or inflammation or exposure to the pollution or sometime prolonged endotracheal intubation. So historically, we can have some idea whether this is primary ciliary dyskinesia or secondary ciliary dyskinesia. Patient usually have these kind of symptoms, prolonged history, usually secondary dyskinesia, secondary ciliary dyskinesia, they have shorter history where the patient is have some inciting agent events. Secondary ciliary dyskinesia are very much common, while primary ciliary dyskinesia is a rare disorder. Secondary ciliary dyskinesia can be there at due to bronchiectasis, due to bronchitis also, due to prolonged intubation also, due to some exposure to the pollution also. Now, regarding the signs and symptoms, usually primary ciliary dyskinesia have multiple organ involvement, while secondary ciliary dyskinesia usually have the symptom of the infected system. Like a patient who is having rhinosinusitis, where the symptoms are only limited to the sinuses, or the patient who is having bronchitis, where the patient is only having the symptoms of bronchitis. While primary ciliary dyskinesia, as Dr. Agrawal rightly said, that it is multi-organ disease where multiple rhinosinusitis, you can have rhinosinusitis, you can have bronchiectasis, you can have situs inversus, so infertility. So these are the clinical features from where we should suspect that patient is having either primary ciliary dyskinesia or secondary ciliary dyskinesia. Regarding the outcomes, primary ciliary dyskinesia is a permanent disorder where we cannot do too much about the patient, but the secondary ciliary dyskinesia is usually reversible. Once we treat the underlying causes, we can the ciliary dysfunction can be regained again. So these are the main features from where we can differentiate between primary ciliary dyskinesia and secondary ciliary dyskinesia.
Okay, so history is very important in coming to clinical suspicion for primary ciliary dyskinesia. So it has to be a term birth and neonatal distress and long history of the upper respiratory and lower respiratory syndrome, and with or without situs inversus or heterotaxia, situs ambiguous. So cardiac defects also may be there. So thank you very much, Doctor. Now we'll move on to Dr. Tridib Chatterjee, sir, adult pulmonologist from Mumbai. Sir, in adult pulmonology practice, again, when do you suspect primary ciliary dyskinesias?
Thank you very much for this question. First of all, I thank the organization and specifically for selecting such a topic. I was not even aware that this is PCD Awareness Week. Forget about the disease. I was not even aware of the week. So it's very, people like us, we've hardly ever or practically never seen such case. And I'm sure so many years ago I didn't know, I'm sure even nowadays. So I congratulate Vijay and Ravi Bhai and all of them who have thought of this. So coming now to your topic. So of course most of the times these are usually diagnosed in childhood. So there is one interesting score called Picard score, which is seen in childhood, which is usually 7 or 8 points are collected. That is a full-time growth, a full-time birth, neonatal respiratory symptoms. Many of them have admitted with, little neonatal distress. Almost 40-50% of them have got situs inversus. Some of them have got cardiac congenital heart disease, persistent rhinitis and otitis media. So higher the score, more the chances. So if we have got a score more than 8, 10, then probably 80-90% of them, 90-95% you can be sure they are having PCD. But having said that, as you said, as an adult, sometimes it may or may not have been, as the other speakers have said, they have been probably thought of asthma and all that and have been treated wrongly. So sometimes they may come up in adults, but most of these adults, when we see them, you will see, and as you rightly said, they have probably gone through that European study. I also read 50 times different doctors. So it's imagine if it happens in Europe, what will be seen here. So about half of these adults will have almost invariably have had some sort of ENT surgery, some sinus surgery, some tympanoplasty. They almost all of them have got bronchiectasis, and they have this situs inverse. About 40-50% will go situs inverse. One thing I forgot to mention, in childhood, this disease resembles cystic fibrosis very much. So you must try to rule out cystic fibrosis and immunodeficiency. Beautiful slide shown by Dr. Nikhil. So those things also have to be kept in mind. As in the EMBARK study, which Dr. Rajadhar, we do the immunoglobulin. So those things have to be always ruled out, because this is not a very common disease. So you must think of the commoner things. And if the adult is having also fertility problems, if he's this is not getting pregnant, and you do a sperm count and you find there is a problem there, and he has the other symptoms, then I think you can then start really thinking and then find a place where you can send for this battery of tests. Thank you.
That was great, sir. And so if you have a bronchiectasis, young bronchiectasis patient with upper respiratory tract involvement, with ear involvement, and long history of bronchiectasis.
Yes.
And if the patient has situs inversus totalis, that's okay. But then if there is no situs inversus totalis, then
the situs inversus is not mandatory. If it is there, it gives an additional clue. If it's not there, still if there are other things, as you said, chronic sinusitis, chronic some surgery, in the childhood, yes, 2-3 baar I have to be admitted for oxygen, or there is a family history sometimes, occasionally, then you have to at least, and immunodeficiency is not there, immunoglobulin, then you have to think of this. Unless you think of it, you would not.
Correct. And one thing about that Picader score that we talked about, that primary ciliary dyskinesia rule, that was before nasal nitric oxide came and before Delta panels were available. So anyway, so it is a clinical prediction tool that pediatric cases, especially even adults, we can use it. Yeah, thank you very much, sir. Thank you. So having brought in this nasal nitric oxide topic, now I request Dr. Jayaprakash, Pulmonologist from Trivandrum, to take us through about the nasal nitric oxide in the scale of primary ciliary dyskinesia.
Thank you, Paramjyothi sir, for the nice introduction, and I thank the Chess Council of India for giving me an opportunity for discussing this very rare and important topic. So the question asked to me is, what is the role of nasal nitric oxide in the diagnosis of PCD? So I will start with a statement that it is the most useful non-invasive screening test for primary ciliary dyskinesia. Dr. Avishek has emphasized all the tests for diagnosing PCD, both invasive and non-invasive. To confirm the diagnosis of ciliary dyskinesia, primary ciliary dyskinesia, you need to have either a genetic testing or a ciliary abnormality to be demonstrated by electron microscopy. But these two tests are not readily available and a little hectic also. Now, what is the role of nasal nitric oxide? What is the principle behind it? We know nitric oxide is very widely used for respiratory disease, both for diagnosis and treatment. It is produced from the epithelial cell, endothelial cell, and activated macrophages. And we know nitric oxide is very much elevated in asthma and in cystic fibrosis, which can be used for the diagnosis of these two conditions. But regarding primary ciliary dyskinesia, the nasal nitric oxide level will be reduced Why? Because of the in ciliary dyskinesia, there is a defect in the ciliary structure, its motility, and the production of nitric oxide is reduced from the nasal and upper respiratory epithelium. And because of that, the nitric oxide level, nasal nitric oxide level will be reduced in patients with the primary ciliary dyskinesia. And the method by which we are doing the estimation of nasal nitric oxide is by chemiluminescence. And the method is called vellum closure method. It's nothing but the patient is asked to hold the breath and a deep exhalation through resistance through the nose. And the instrument measure the level of nitric oxide. In healthy people, it will be usually more than 250 nanoliter per minute. But in patients with primary ciliary dyskinesia, it will be dramatically reduced to below 77. That is the cutoff fixed. But in most of the studies shows that the level of nasal nitric oxide will be less than 30. And if it is reduced below 30, it has 98% sensitivity and 96% specificity. So to emphasize, the nasal nitric oxide level will be reduced in patients with the primary ciliary dyskinesia. But doesn't mean that it is a diagnostic test. It's only a clue that there is a possibility of primary ciliary dyskinesia, and that patient need to be confirmed with high-speed video microscopy or an electron microscopy or genetic testing. Number two, a patient or a person who has suspected PCD, primary ciliary dyskinesia, with a normal nasal nitric oxide will not or does not rule out the possibility of primary ciliary dyskinesia, and so much so that the nasal nitric oxide estimation should not be used as standalone test for the diagnosis of primary ciliary dyskinesia. Children below 5 years cannot be able to do the so-called vellum closure method, which is little strenuous. We can do the normal breathing test, and which also has very good sensitivity and specificity. And recently, the chemiluminescence is little technically high thing, but we have an electrochemical analyzer being manufactured in different institute just to do the nasal nitric oxide level in patients with the PCD. So to recap, the role of nasal nitric oxide is a very useful non-invasive screening test, and it will be reduced in patients with primary ciliary dyskinesia, but that test cannot be used alone for the diagnosis of PCD. Sir.
Thank you, sir. Thank you, Dr. Thanks for telling us the point that it is just a screening tool, and normal values does not rule out PCD. And if there is a low level, you have to recheck once again, whether it is truly low. And this is not a standalone test to make a diagnosis of PCD, but it will help us if the values are too low in clinically suspected patients of PCD. Okay. Thank you very much. Thank you very much. So now we move on to the second section in this PCD panel discussion. It's on imaging, functions, and genetic testing. Now we'll go to Dr. Nikhil Gupta once again. Once again, can you just tell us about various radiological or imaging findings in specific to primary ciliary dyskinesias, and if we can differentiate from cystic fibrosis and primary immunodeficiency disorders. CT scan or other investigations also with respect to cytosine, proteins, and vascular anomalies.
Yes, sir. Thank you for this question, sir. Now, the specific findings to PCD are, as we have all discussed, situs abnormalities. That is situs ambiguous, situs versus totalis, heterodoxy can be there, or actually these are the strongest clues to the PCD. Then there is chronic rhinosinusitis, sinus hypoplasia may be there. So on CTP, we can always do a CTPNS additionally for the sinuses. And then the bronchiectasis itself, which generally affects the middle lobes or lingula, middle lobe or lingula, right? Middle lobe or lingula is there, and there on chest X-ray we can see the situs abnormalities plus there is the cardiac borders are not so well defined if middle lobe and lingula is involved, so we can see that. Also, we can see for the collapse of the middle lobe, that is also a frequent finding there. Then there is bronchial wall thickening. We can see on X-ray, on CT, on MRI, and there is air trapping on expiratory cells, which is also important. So there can be mosaic attenuation, or there can be direct air trapping. We can see. So a combination of these features is generally seen in PCD. We can differentiate it from cystic fibrosis. There are three important points here. One, the cilia are motile. So mucus is normal, but cilia cannot move now. So we can do a mucus testing. Then ductus difference is normal and not obliterated, which is obliterated in cystic fibrosis. So forms are abnormal in immotile cilia syndrome, that is PCD, and the radiological findings are milder in PCD and then cystic fibrosis.
For my understanding and for the understanding of the audience, can you just explain what is this situs ambiguous or heterotex?
Situs inversus is like complete situs. Heart is on the right side, stomach bubble, and then spleen is on the left side.
Very predictable findings in situs inversus. And
sometimes there is something in between, like both lungs have two fissures, or there may be 3 fissures on the left side, like that, and there is polysplenia, and these are mostly these are the findings in heterotaxis syndrome, where we cannot clearly say that it is dextrocardia, dextro-posed heart, or that includes this heterotaxis syndrome. So.
No, because this is going to be very important when intervention radiologists have to plan some intervention radiology, intervention procedures, so they have to have this connected information. So thank you very much. So now we move on to now that we know there are more than 55 genes involved in the pathogenesis of cystic fibrosis. So each year new genetic panels are getting upgraded. So I'll go to Dr. Avishek Agrawal. In his opening talk, he said it is an autosomal recessive disease, but it could also be autosomal dominant. It could be X-linked also. So not always autosomal recessive. So Dr. Avishek Agrawal, can you just tell us about genetic testing and the panels that are now available, and what is the future about this genetic panel testing? I know none of these tests are diagnostic of PCD. They add to the probabilities. So Dr. Avishek Agrawal, genetic testing but primary ciliary dyskinesia.
Yes. Hello. Hello.
Yeah, we can hear you. We can't see you, but we can hear you.
Sir. Okay, sir. Sir, actually, what genetic testing you are asking me? Genetic testing, which is available in DDI, is more toward NGS and whole exome sequencing. first thing what people used to do, because there are actually in genetic we will see a multiple heterogeneity in PCD. More than 50 genes are diagnosed to having known to cause PCD. First thing, and second thing is key. We are still working on it. Key more genes are day by day we are diagnosing key causing PCD. So in genetic testing, I would suggest, if possible, and if there is patient is actually payable, we will go for whole exome sequencing, because there are also sequencing genomics is also possible. We would say broad respiratory genetic panels and other panels are also available, but at the end, if you are not end up with a genetic negative, you can't say that this is ruling out PCD. So you can go for whole exome sequencing. It is a best thing. We can go for in genetic. Other test available is emerging AI assisted generating genes, also evaluating in emerging techniques. So that is also helpful in diagnosis. Now we will pass to next generation sequencing. This is a modern technique and with a high resolution, in which we can target a gene, and targeted gene therapy can be given based on nucleotide DNA and RNA by simultaneously sequencing million of small fragments. But still we are in this era, we can opt for NGS and whole exome sequencing in PCD.
Okay, so that would also look into cystic fibrosis also. So if you use the
ruling out cystic fibrosis also, yes sir.
Use only targeted panels. With a limited panel, you may miss the PCD. So if you use the extended panel, you are more likely to pick up the pathogenic variants. We have pathogenic variants and variants of clinical significance. So each year, as I said, new and new mutations are being discovered, new genes are being discovered. So yeah, so next would be a whole genome sequencing. That's again very expensive, not available, but that's for future. So with that, we can identify some more genes for better diagnosis of PCD. Yeah. So thank you, Dr. Now we'll go on to Dr. Vikrant Ranga. Can you take us through the other diagnostic tools that are available for diagnosis of PCD, like transmission electron microscopy or high-speed video microscopic assay, or immunofluorescence, if you wish to talk on immunofluorescence also?
Yes, sir. Thank you for the question, sir. So transmission electron microscopy, and earlier it was a gold standard for diagnosis of primary ciliary dyskinesia. Hello.
Yeah, we can hear you.
Hello.
We can hear you, sir.
Yes.
We can hear you.
Sir. Okay. Transmission electron microscopy, earlier it was a gold standard for primary ciliary dyskinesia, but it has certain limitation on its own. Like it can detect only the sensitivity is around 70 to 80%. So still there are some limitation where we cannot detect primary ciliary dyskinesia by the electron microscopy. Other limitations of transmission electron microscopy is that it can detect only the structural changes of cilia, and it cannot detect the functional changes of ciliary dysfunctions also. So for transmission electron microscopy, you need to have a good sample of nasal or bronchial mucosa. The other test we can have immunofluorescence test and genetic testing, where the whole genome sequencing is nowadays is upcoming, where we can detect in genetic sequencing, we can detect more than 50 genes, where we can have the hello. Hello.
I can hear you, sir. Go ahead.
Okay. So whole genome sequencing is a new addition to the tool of for diagnosis of these primary ciliary dyskinesia associated with, along with the transmission electron microscopy. And now regarding the transmission electron microscopy, we need to have a good sample of nasal or bronchial mucosa. Hello?
Yeah. Some connectivity speed issues.
Can hear him. I think he's.
Anyway,
Hello?
yeah. So we can hear you, Dr. Vikrant. So you were talking telling us about
Okay, sir. Okay.
transmission electron microscopy is to pick up the anatomical structures of the cilium, and
I'm not able to.
high-speed video microscopy is all about the ciliary pattern, and genetic testing about to pick up the mutations in the genes with the pathogenic, and immunofluorescence is that see for missing proteins in the cilium. Is that
I think he's not able to hear us.
okay?
Hello?
Dr. Vikrant, can you hear us?
There is some network issue.
There must be some network issue, I guess.
Because we can hear you. Maybe you can switch your video off and just stop your video. Dr. Vikrant, you stop your video and see.
Okay, sir.
Now you see.
Yes,
now
sir.
you
Yes, sir.
talk.
Definitely.
Now you talk.
Sir, I'm not able to get the question.
So we're just trying to know what is transmission electron microscopy and high-speed video microscopy, immunofluorescence, for genetic testing we have already talked about. What do they tell us about these tests? What do they tell us, and what is their role in the diagnosis? Is that okay?
So transmission electron microscopy. Hello?
Yeah.
Transmission electron microscopy is a type of electron microscope where we can detect the tubular structures of the cilia, and where we can have ciliary dysfunction or any abnormality in the cilia. Where the high-speed electron microscope, high-speed video microscopy is where we can detect the beating of cilia, pattern of the beating of the cilia, where these cilias are moving in the same coherence, or it is moving in a different coherence, or there is any change in frequency of beating in the cilia.
Okay. So having known about these tests that are available, it is important to know once again that none of these.
Sir, as far as these tests, I have said where the electron microscopy, transmission electron microscopies are available in India. I think there are a few centers which are where these are available. I think one is in the AIIMS Delhi, and one is in Amrita Institute, where electron microscopy is being done. There we can have these kind of, but these tests are very limited tests, and we have certain limitation of these transmission electron microscope.
Correct. So these are centers, these are the centers of excellence, not totally available. And point that is to be remembered is a normal TEM, transmission electron microscopy, a normal doesn't rule out PCD. So also a high-speed video microscopy, normal doesn't rule out PCD.
Yes, sir.
Even in immunofluorescence.
No,
tests 100% sensitive or specific. So there are some issues. So we have to interpret them in clinical context. Okay.
Correct.
Thank you. Sir, we'll go to Sir Chatterjee, sir. Can you just talk to us about in your clinical practice this dextrocardia, situs inversus, cartilaginous syndrome?
So taking up from where you asked, you said, sir, again here the most important thing is the clinical thing. The clinical thing never goes. That's the primary thing. So if you have got a child who's got a cartilaginous, who's got a situs inversus, and he's got chronic sinusitis and a PCD, then that situs inversus is absolutely significant. But by and said PCD, only 40-50% of them will have cartilaginous. But without that situs inversus, if the patient has got, or let's say somebody comes in adult and has got a situs inversus, it is it is, you have to actually ask whether there are any clinical features. If the patient is having had cough, because other than PCD, there can be also congenital heart diseases. There can be polysplenia, there could be asplenia, which are related to situs inversus. So just dismissing it is not the way. But it doesn't mean that, oh, you got situs inversus means you now have, you have to do it. But at least it is giving you a scope to go into little bit of the history, check the other organs, maybe do an imaging, and try to go to take a step further to find out if it is a benign situs inversus, which is possible and it is not uncommon, or it has got some PCD being one of the main things, but as I said, some other organ involvement also. So that is what the present clinic, where, so here your clinical input is absolutely essential. Thank you.
Thank you. Thank you, sir. We will move on to Dr. Jayaprakash. Sir, can you tell us about a little more into the genes involved in cystic primary ciliary dyskinesias and this is so heterogeneous genetically as well as clinical phenotypes also. So, can you take us through about the genetic genes involved and the lung function decline or clinical phenotypes? Can you, is there any information on this?
Okay, thank you, sir, for the question. And the question asked to me is whether the genetic abnormality, and as we know, PCD is a disease with more than 55 or 60 gene defects. Every day we are detecting more gene defect in primary ciliary dyskinesia. And genetic test will determine the genetic abnormality, and the structural defect will be determined by an electron microscopy. So these are the two tests which reasonably confirm the diagnosis. And if you look and ask the question whether a specific genetic defect or a specific extrastructural defect, if you determine by genetic test or with electron microscopy, can you predict the worsening, the survival, the prognosis of that particular patient? My answer is yes. You just remember our old anatomy or the microscopic structure of cilia. The defect which happens in cilia in PCD is either the dynenams or the radial spokes will be usually defect. But if the cilia as such is less in number and it is not moving properly, that patient, if you identify in electron microscopy and in genetic study, if there is a gene called CCN0 or MCA-DAA5, if these genes are also defective, that patient will have a severe PCD and very quick worsening. So that patient has to be very meticulously followed up with very quick follow-up. On the other hand, if the dynenam is defective, if the outer dynenam is defective and corresponding like DNA H5, DNA 11 or DNA H9 genes are defective in that patient, these two groups, that means electron microscopy showing an outer dynenam defect or genetic study showing this DNA H5, DNA 11 or H9, that patient will have only a moderate reduction in the lung function in the follow-up period, and they are likely to respond to treatment, live for a long time. But if there is an outer arm defect plus an inner dynenam defect detected by electron microscopy, along with genetic defect, that patient will have a quick deterioration in lung function and disease progression. Suppose there is a defect which is detected in the microtubular disorganization. Correspondingly, there is a genetic defect in the CCD39 or CCD40. That patient also will have a rapid progression. And if there is a radial spoke defect detected by electron microscopy, or there is a genetic defect, the RSPH1, these numbers are difficult to remember. There is RSPH1 or RSPH4A. If these genes are defective, that patient will have a very slow or a mild progression. So what is the significance of knowing this specific genetic abnormality or the specific defect in the electron microscopy? Looking into that, we can predict the decline in the lung function, the progression of the disease, so much so that we can direct your therapy, we can predict the survival and predict the prognosis. So the answer is whether specific genotypic identification or a specific ultrastructural defect determination is useful in terms of diagnosis and treatment? The answer is yes.
Thank you, sir. That was excellent presentation. Thank you very much. So now we move on to the next section. Dr. Nikhil Gupta, how often we have to repeat the CT scan? I mean, once you make a diagnosis of PCT, how often do you have to repeat imaging in general, or is there any other imaging modality whereby we can follow up these patients without radiation?
First of all, whenever there is new exacerbation or new focal symptoms, then we have to repeat CT or chest X-ray. And it should not be done in asymptomatic people. Like we have reached a diagnosis, and we should not routinely do these tests like in 1 to 2 years time. We can repeat them after like we can repeat X-ray in 1 to 2 years or CT in every 3 to 5 years, depending clinically, or earlier if there is some clinical problem. Then alternatively, in young adults or children, we can also do MRI chest. It is upcoming and there is no radiation. We can assess bronchiectasis severity, bronchial wall thickening, mucus plugging, consolidation, or we can also do perfusion with contrast. But there are some limitations to MRI, which we all should understand. It is costly, number one. Longer time is required. So children may require sedation. And there is a lower resolution of MRI than HRC. That is the most important. So this is also MRI can be used for periodic monitoring. Guidelines says 1 to 3 years should be enough if exacerbation or new clinical symptoms are not there.
Oh, thank you. So now we move on to Avishek Agrawal. The patients with PCD in adult practice usually come with bronchiectasis. So the main non-pharmacological arrangement of bronchiectasis is airway clearance techniques. So which airway clearance techniques do you recommend for pediatric bronchiectasis in the primary ciliary dyskinesia?
Yes, sir. Sir, actually, what we prefer in PCD are different method for airway clearance technique. Like first thing, modified postural drainage without head treat drainage, which is based on gravity. Second one, hello.
Go ahead.
Second is autogenic drainage. Active cycle of breathing technique also there is, ACBT technique, West therapy, positive expiratory pressure technique, oscillatory PEP, high flow frequency chest wall oscillation. These are the technique what you used in pediatric patient and adult also. For all age group, we can use PEP and oscillating PEP for all age. For children above 5 years of age or 4 years of age, we can go for active cycle of breathing technique and oscillating PEP. The technique what I called autogenic drainage is used for the children above 8 years of age, sir. So these are the technique what we use in pediatrician and in adult also.
I mean, do you use a normal saline or hypertonic saline?
Yes, sir, definitely we are using hypertonic saline, 3% to 7%, depending upon the consistencies of the mucus and this we are using. Apart from this, we use antibiotic therapy also here. And the difference with cystic fibrosis and this is we never use DNS or rarely use DNS for PCD.
You said DNAs?
DNAs we rarely use for PCD, sir, and we are using it frequently in cystic fibrosis patient.
Yeah, so that have a role in specifically cystic fibrosis bronchiectasis,
Yes,
and for non-cystic fibrosis bronchiectasis. Well, at least it's not available to us. It's available to you. You're using it. Fine, right? Good. So next, we'll go on to Dr. Vikrant Ranga. We know that there is no specific treatment for primary ciliary dyskinesia as of now. But those patients with frequent bronchiectasis, with frequent exacerbations, in patients with primary ciliary dyskinesia, like in other non-CF bronchiectasis, can we talk about long-term macrolides? Because we know macrolides have anti-inflammatory and immunomodulatory and different diaphragm information. So, any information on long-term macrolides in the setting of primary ciliary dyskinesia and bronchiectasis? The question is to Dr. Vikrant Ranga. Is with us? Vikrant Ranga.
I think he has some connectivity issue, I think, sir.
Even last time he was not.
Oh. We move on and then, if someone asks this question, we can answer later.
I don't.
Macrolides. Peacefully related bronchiectasis. Shall we move on, sir? Shall we move on to the next topic? The next panel.
At least whatever I know of macrolides is for adult bronchiectasis. Well, I don't know whether it can be extrapolated for this. For adults, there have been various studies where you can been using up to a year also. Sometimes you can give a gap, but that's the only, and of course, preferably it's when you have Pseudomonas as the main organism. But I don't know about whether it can be used for.
There's a trial called Best Cilia trial, the RCT trial. And
maybe you can, if you know, you can just tell us.
PCD with bronchiectasis, frequent exacerbation, found to be useful.
I see. Great.
Personally, for bronchiectasis, macrolide azithromycin is useful, sir. That's my opinion. But replicating this into primary ciliary dyskinesia bronchiectasis, I don't have any personal experience. But I had a patient of cartaginous syndrome. That patient having frequent exacerbation, I put on azithromycin 500 milligram thrice weekly for 6 months. That 6 months and a few months later, he had minimal exacerbation compared to the previous year, sir.
Yes.
So yes, sir. In pediatric also, we can use azithromycin for PCD and for longer duration actually. But yeah, we definitely give a holiday period in between, and then we are continuing it.
Yeah, sir, organism. Sorry, you go ahead. You finish.
So, the major difference what we use in cystic fibrosis and PCD is, sir, in cystic fibrosis we use antibiotic regularly, but in PCD we use specific antibiotic according to the organism based on culture. So that is the reason that if the organism remain the same, Pseudomonas, H. influenza, you can go with azithromycin also. And based on the sensitivity pattern, here we use cautiously. In PCD, we use antibiotic cautiously with the organism and culture basis.
So going on from your question, should you rule out NTM before you do the macrolide therapy?
Whenever we are describing a long-term macrolides, you have to rule out You have to rule
That's
out.
what I wanted to just bring out that point actually.
You have to rule out NTM and carefully follow up the cardiac rhythms and
definitely tinnitus,
to be monitored in those patients. So that's why I call here we are giving azithromycin not as an antimicrobial, but as an immunomodulator, anti-inflammatory to prevent. I call azithromycin as a poor man's biologic. I use this even in
good.
Those who cannot afford biologics, be it a T2 asthma, T1 asthma, those who are eligible for biology but cannot afford biology in asthma. So, yeah, that's another debating point. But any
Network issue.
the modulatory anti-inflammatory drug. Yeah, so shall we move on to the next topic, sir? Sir, Dr. Chatterjee, sir, the question is about lung functions. It's already discussed about the types of lung functions and the foreign lung function. How do we follow up these patients with PCD?
Yeah. So in a stable adult PCD, I don't think we require. I mean, quarterly should be good enough. 3-4 monthly is quite okay. You do not have to do it early because but it has to be also done because that drop in FE1 and FEC can be the first sign of that there could be deterioration. There is one important point here that when you do the lung function, is preferably we should try to stick to one lab because sometimes there is a variation and you must check the loop properly. There is no coughing, etc. The quality of the flow volume loop should be checked, and preferably to avoid doing it in the infective exacerbation. If the patient is at that time having a lot of cough and he's on some antibiotic, etc., maybe you can wait for that to settle, and when he's a bit stable, then do the lung function. So that will give you probably a better idea. But yes, 3 to 4 monthly, definitely you should keep doing it. And for how long? That is as long as the patient is with you. You have to do that.
So,
there's no way out.
Spirometry part, now we have the luxury of IOS. You can use it in children.
It is iOS can also be used, but I don't know whether specifically for PCD there is any. But extrapolating it, maybe it can be that.
Yeah. So those who cannot do spirometry or children
can be, or who are coughing a lot can be.
It's another way of documenting the lung functions.
Yes.
Though not standardized, but something is better than that.
In fact, in my case, I almost invariably, even in a COPD, I do both the two. It just adds on to it. Although Gold may not have, talked about it, but we have in practical experience found it to be useful in many cases. I'm talking about COPD, but maybe you can extrapolate it here also.
Correct. Okay, sir. Thank you very much, sir. Thank you for sharing your knowledge. We'll go to Dr. Jayaprakash now. Sir, as we have already said, this is a multi-system disorder where multiple specialties have a role to play, be it in diagnosis or in management of this disease. So, can you just take us through the other specialties, pulmonologists to come into play in management of?
Okay. Sir, as you, Paramjyothi sir, you also mentioned the diagnosis, the evaluation and management of primary ciliary dyskinesia should be a multidisciplinary management team. But since it involves the lungs and upper respiratory tract predominantly, I think a pulmonologist and ENT doctors will be predominantly involved. But don't forget the role of a physiotherapist and microbiology in the management of primary ciliary dyskinesia. So there are three components: initial evaluation, the diagnosis, and treatment. So I think the initial evaluation, diagnosis, and treatment should be when a pulmonologist is evaluating, it should be in concordance with an ENT doctor. So talking about the initial evaluation, whenever a child or a person is having recurrent wet cough with, you have to suspect primary ciliary dyskinesia, and you have to refer the patient for an ENT evaluation, and they will look into the assess the chronic rhinosinusitis, the otitis media, whether there is a hearing impairment for that particular patient. After the initial index of suspicion, the pulmonologist will definitely do a nasal nitric oxide as a screening test. He may do an HRCT for diagnosis of bronchiectasis. If facilities are available, or you can refer the patient for a electron microscopy for a genetic testing. On simultaneously, the ENT people or ENT consultant can do a nasal brushing. He can arrange a nasal brushing for doing the electron microscopy or for genetic study. And coming to the treatment, pulmonologists are well versed in the treatment of bronchiectasis, including the chest physiotherapy, the inhalation therapy, inhaled medication, and other drugs. But that treatment should be in concordance with the ENT. If there is an ENT infection, you can use a common antibiotics in discussion with the ENT people. But they will be concentrating or they will be helping you regarding the nasal saline irrigation, nasal mucosal clearing, and sinus toileting. Don't forget about the infection control, which also, or the monitoring of the patients, that also you can do along with the, with the ENT people. And the review also you can plan once in 3 months or once in 4 months. The same date can be given for both ENT and respiratory review so that both the specialists can see the patient at a time. And regarding the emergencies and secondary infection also need to be counseled both from the pulmonology and from the ENT side. And a patient and family counseling also has to be done both by the pulmonologist and the ENT. So in one word, a close or a concordance or a combined decision making by pulmonologist and ENT doctor will be the most useful in diagnosing and managing the case of primary ciliary dyskinesia.
Yeah. So adults in young age group, in the reproductive age group, they may have fertility issues also. So that also will be taken care by the experts in that specialty.
Correct,
so
sir.
Sometimes it so happens that when they are evaluating for primary infertility in men with the frequent respiratory chest symptoms, PCD will be thought about. So they can go to primary infertility. Subfertility is also an issue, so they may go to fertility clinics also. So now we'll go to Dr. Avishek Agrawal. Once you have a child with strong suspicion of primary ciliary dyskinesia, when do you screen the asymptomatic parents, or do you have to screen them and the sibling? Genetic screening, or otherwise?
Yes, sir. Sir, this is the actually real life problem. And when we come to PCD and the another child we have, this is the real problem we are getting. I understand your concern, sir. When one child is affected with PCD, it's natural to wonder about the other child and the siblings. But first thing we know ki PCD is mostly autosomal recessive condition. Yeah, rightly said by Paramjyothi sir, it autosomal dominant and X-link also seen. But in general, it is an autosomal recessive disorder, which means there is chance 1 in 4 child to be affected. 1 in 2 child would be carrier, and 1 in 4 child is totally healthy or unaffected. So even though if we know what is the condition of the child, if the child is healthy and that gene came positive, we are just keep a watch, nothing to be done as a treatment part of basis. Second thing, sir, if we know the actual specific gene of the first child, we can go according to the specific gene sequencing for the second siblings if insisted by the parents. First thing, we counsel them about the condition, even though if it came positive and the child is healthy, we are not going to start any treatment. The only thing what they can do is keep an eye watch to the red flag sign. If any symptom like wet cough, chronic rhinosinusitis, middle ear infection, or growth faltering has been seen, then we will move forward. First, second thing to sir, unnecessarily doing the test will increase the anxiety and problem to the family, and also increase the financial burden, sir, because genetic testing at the end of the day is very expensive. So from my point of view, sir, and clinical message from as a pediatrician, sir, I would recommend universal sibling testing is not recommended. Second thing, target testing appropriate if variant known or symptom exists, sir. Third thing is genetic counseling always before testing, so that they come across what to do, what not to do. Their concern was if the child is asymptomatic, what next? So it is helpful if the child is asymptomatic throughout the life. It is helpful for the partner choosing or in the marriage. So genetic counseling is important point of view. Family education is the key role in recognition and reassurance in this case.
connectivity issue. Can you hear us, Dr. Avishek? Can you hear?
Yes, sir. Yes, sir. Right now, I'm able to use.
Okay, then. Okay. So thank you, Dr.
Sir, I just wanted to add one thing here, just to what he said. There is this, as being this autosomal recessive, there is it being quite common in consanguineous marriages. So, if by chance it is certain communities this is happening. So, if one child is already having this PCD, maybe you can counsel the parents at that time that the second child.
Sir, we'll come genetic counseling.
Okay. Sorry. Okay. Fair enough. Sorry.
Yes, sir.
The next.
No, it's okay. If you're going to talk on it, we'll skip that talk now.
Yeah. So, Dr. Vikrant, Ranga, if the parents agree to go for genetic testing and the siblings also, and having done genetic testing, how do you counsel the parents and the child as he grows up? What do you tell the parents? It's very, it's an emotionally charged situation, but how do you counsel them?
Yes, sir. That is very genetic counseling is very important in primary ciliary dyskinesia patient, where we can have the patient who are carrier, who are having asymptomatic carrier also, who can have also the patient who can have more virulent variant also, where the patient can have bronchiectasis or patient can have severe bronchiectasis or respiratory distress. So genetic counseling becomes important in this setting, where we can tell the patient attendant that you should do frequent monitoring of the symptoms, or we can have prenatal genetic testing also, where we can detect the offending genes or the genes which can cause these type of symptoms in like bronchiectasis or respiratory failures. So prenatal and pre-implementation diagnosis is very important. Once we get the familial mutation, once we get the mutation of that family, that these kind of the mutation are in the family, so we can counsel them that you can have these kind of symptoms. You should follow up regularly. You should see the symptoms of any otitis media or any bronchiectasis or any respiratory distress. So family screening, for further family screening is also important, and early intervention, like in terms of avoidance of infections, monitoring lung functions with physiotherapy also for younger siblings is also very important.
Yeah, so it does have a role, at least in our part of this part of my area. Consanguineous marriage is very common. So if you have a carrier, you can advise the parents to better be careful, at least to avoid consanguineous marriage. So but having said that, it could be extreme disease or autosomal dominant. So, anyway, so if the parents are willing, you can send them to the medical genetics people. So medical genetics is a department that is next to my department. So we interact with medical genetics department, and genetic counseling is done where they are the experts in genetic counseling. Thank you. Sir, Chatterjee sir, this is a disease which is and from childhood they lose symptomatic and adults. It's a huge psychosocial problem, and lifestyle issues will be there. So can we just talk about quality of psychosocial?
Yes. So I will answer your question with one interesting story which I read about one. I think that she looked like a early European lady, where she just describes she's a confirmed case of PCD. So she describes her life that she gets up early in the morning at 6:37, and she first does steam nebulization, all the saline nebulization, 3%. Then she takes her aerosols. Then she spends half an hour doing chest physiotherapy, trying to clear up. This is when she's stable, not when she's. and then she wears a mask and she goes to work, and then somewhere she works, and then she comes back and again does all this. In the work period also, during the lunchtime, she does a chest PT, she may be carrying a portable nebulizer and doing it there. And in spite of all that, she has to skip her duties. And when she's stable from outside, you can't make out that. So people think she's maligning. So this is an extremely difficult situation for a person. I'm talking about an adult. So imagine a child, and along with that, the parents going through that. The cost, and in an adult, in addition, I did not mention that this lady may not be able to reproduce. She may have to use adoption or some, if not adoption, at least some other assisted modes through the gynecologist. So this is something which requires, maybe you can even get as in one specialty, as Dr. Somebody mentioned that multidisciplinary, maybe you can get a counselor also involved on board, and explain to the counselor that this is a medical problem. How should we counsel the patient and the parents in the case of child? So it is something which is, there are no guidelines. It is something you sort of learn as you go along and with the help of others. That's all I could think of. If you have anything, anybody wants to add?
Yes, thank you, sir. So that brings us.
Counseling is still in very undermined in India. Also, I think we haven't done any genetic counseling till now, and these are the area where we should think of regarding the early genetic testing and early genetic counseling of the patient. And in the Western countries, they are doing it. But in India, I think we are lacking behind the genetic counseling and genetic testing also.
Yeah,
like
but
for example, in Bombay, but for the familial ILD, we have a center here which does this genetic testing and the counseling. So there, I just talked to that lady. That it's very difficult. I'm talking about ILD, but I'm sure it will be here. So you may have the gene, which you may not have the disease, or you may not have the gene, you may get the disease. So it's not so easy. It's extremely tough, and as you said, we are probably in the infancy stage. So
yes, sir.
We cannot
Actually,
people who are specialized in that. Only they should be talking about this.
Right.
Medical
But when they
genetic
come to us as a patient with PCD, we have to support them, give them that look. If you do your physiotherapy, if you do your thing, you do your lung functions regularly, take your vaccinations, which is a very important prophylactic part. Avoid this dusty. Maybe you can live, live a reasonable life, normal life, and with some fertility things you can tackle by adoption or whatever. So that support is something which, as at least adults, if PCD patient come, we can give without going into detail genetic counseling. I'm talking about counseling of the long treatment and the financial burdens, the mental burdens which you may be able to give.
Chatterjee, sir, for your knowledge, this sir, in Mumbai only, in Wadia, when I was there for my study, there are actually genetic counselor and rehabilitation teams, sir, in Wadia, sir. And for their normal financial, psychosocial, and the mental trauma what parents are going and the child is going through, the rehabilitation team counsel about them.
This is for PCD?
Yeah, for many diseases, for any disease. Yeah,
great,
but
great.
they
So
include PCD also.
Great. So these are the rights. Paramjyothi sir said we should refer to such people. We should take the help of these experts because we cannot do everything here.
Correct. Yeah. So now we'll move on to Dr. Jayaprakash sir. Sir, can you take us? What's the rare disease and the lack of Indian disease? We have a lot of this bronchitis Can you just talk us through about the registries, their importance, and so that data collection and research.
So, as you rightly said, unfortunately, this is an important problem. In India, there are only few centers which even do research and proper diagnosis and treatment of PCD. And unfortunately, we don't have any Indian registries as of now. Even, but there are global scenario. There are multiple registries. So there is an international PCD registry with more than 24 countries joined together, and even we can also put our data there. There is European Lung PCD Core Committee and or European Lung PCD Clinical Trial Network. Both are Europe-based, and there is a PCD Foundation USA, and there is a Swiss Primary Ciliary Dyskinesia Registry run by Switzerland. All these global registries are well working, but unfortunately in India we don't have any Pakka registry. And the person who did maximum work in India is Dr. Rajadhar. I had a word with him because I could not find out any registry in India. He told me that he is planning to do a registry very soon in the coming year or this year itself, and probably those who are working on PCD can join in that registry and update our data. And All India Institute of Medical Science, CSI New Delhi, CMC Vellore and Manipal Hospital has facilities to do genetic studies and the electron microscopy study in certain centers. There are work going on in AIIMS New Delhi. They recruited more than 200 patients into their study, and soon they will be publishing the data. That's what my knowledge is.
Oh, thank you, sir. Even in our medical, we do see a lot of these political young also. So yeah, it's whatever. So there is a need for us to have our institutes to rare disease, so that we can compare all the patients. Standing on the disease. One of the diagnostic tools showing the available in India, but they are so expensive. The expertise is not readily available. So there is a need to develop different and even we can trials, ongoing trials.
So your voice is not coming very clearly.
Yes, it's breaking. It's not at all clear.
So I was just talking.
Yeah, now it's okay.
If anyone wants to talk on the ongoing clinical trials,
I think what Raja is going to do is, I think the embark which he is further, that is the right, he is the right person, because we have that data already on bronchiectasis.
Yeah.
So if, I'm sure Raja would take up these cases, and I think all cases of PCD should be referred to him. The data should be sent to him so he can make one. He's one of the very brilliant persons. So if he can, incorporate, we'll have some sort of registry along with the.
I agree. There is a need. There is a need for this.
100%.
The clinical trials that.
How many?
Yeah. Sorry.
Hello.
Hello. Yeah.
Hello, Dr. Chatterjee, sir.
Yeah.
I just want to ask how many PCD patients you have seen, sir, in your whole, whole experience and figure.
No, not at pediatric. I have seen just one in adult. That also he had cartridges, and he had lot of cough, and somehow it just struck me, and I have absolutely zero pediatric experience, so I don't have. I'm being very frank about it.
So
that's what
have a
the diagnosis very rare, or we are not. I think we are not thinking in that term that patient should have who is having early bronchiectasis or sinusitis or otitis media. We are not thinking in that term that this patient could have uh, PCD. So I have also seen the one patient at Patel Chest Hospital who was having all the symptoms of primary ciliary dyskinesia, and she was diagnosed. She was young female, and she was diagnosed. So very rare disease, and I think we should
And how common are
think in that
these tests available? How are they free? This nitric oxide, all that, is it available very except AIMS and one or two places was mentioned? How well commonly?
genetic testing, sir.
Genetic testing, whole genome, I think, may be available in some places, but it is extremely
Genome is
expensive.
available, sir, but transmission electron microscopy is available. When I searched, it is available at AIMS Delhi.
That I said also. And what about that nitric oxide as a screening? Is it freely there?
So,
Nitric,
not routinely.
Not sir, not that freely available. Not that freely available,
not
sir.
that.
Actually, even though if you advise for it, patient have to wander here and here, and they don't get actually it done.
And
Yeah.
even if it's available, there are technical issues to be done properly. And normal doesn't rule out PCD.
Normal does not rule.
Yeah.
And sir, actually here also multiple repeated investigation required in nasal nitric oxide, sir.
That is
Because of unexpertise people doing this.
I think the European registry, which was recently put up, has said that there is no one test. You have to probably do multiple tests to come to a 100%.
correct.
Of course, sometimes you may get it, but if you don't get it, it's not ruled out.
Yeah.
Keep on doing.
That we have discussed absolutely diagnostic of tests in clinically suspected cases. So, and these are very expensive. And the reason why I think we have this webinar is to increase awareness of this.
Yes, yes.
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 We should be aware.
Awareness to the pediatrician is more important, I think, sir.
Yeah, pediatric.
And to adult also, please. I will go aware. Yes, today than I was yesterday. I'm sure.
So diagnosing PCD in a patient without situs inversus is challenging. If you have a situs inversus cartilage, that's okay. But
Yes.
when in adult patient, you have a young bronchiectasis with the squared all history of squared
Correct.
TMP issues, then you suspect PCD in this patient.
Yes.
There is no
Correct.
situs inversus in this patient. As I said, we have a medical genetics department, so we do go for genetic testing, whole exome sequencing. So that will pick up because we want to rule out if it is an upper fibers, we go for fibers genetic testing. So, or if it is middle and lingular and middle lobe NTM and PCD is so we go for genetic testing. So, some tests, some genes we are able to pick up. We have data. It's not that it's not done. We do have that data. So unless we are aware of this condition, so we will not ask for it or look for this. So is there anything that any panelists would like to share? I don't know if there are any questions. Audience.
Check the chat box or something.
Yeah. I did not find any questions so far. So.
We can ask the technical expert whether there is any questions.
There are any questions? Okay.
We had just 1,700 or something odd logins as per Dr. Krishna. So that's a good number, and thanks to you, sir, you have arranged it very well. The whole moderation very nicely done.
If we have time and if anyone is interested to share something, I think we still have time. So, Did we miss anything on this? So the important thing is that we should have this disease in mind when we have, especially in adult young bronchiectasis patients with middle handling, singular lobe or lower lobe involvement with long history of respiratory symptoms.
Because generally we don't do, we just send the immunoglobulins, we just say the sputum culture, we do ABPA testing, blah blah blah. But we don't, I mean, doesn't come to our mind. But now that if there is this other history, then at least we can think of, and even if there is no inverses, you can have it, go ahead with us, think that, pehle se hota hai, from childhood I've had, this is something which, then you can try to send somewhere where sequencing can be done, or you can at least think of it. If you don't think of it, then it ends there.
We do ask for genetic testing, and sometimes in males we ask for semen analysis.
Semen analysis, that's
we do ask. So, what the thing is to have this entity in your mind, dealing with chronic risk, especially if the illness starts from childhood and ruled out the cystic fibrosis and
rule out the common things, and then you have to.
Yeah.
That is the whole purpose of this webinar. All of us, we have learned today a lot. I'm sure all of us have learned.
Yes, that is. With that, I thank all my esteemed panelists for sharing the information, and thank the organizers for giving us time to know about this disease. Thank you very much.
Thank you, sir, for very good moderation.
Thank you, sir, and sorry for the inconvenience. I have some network issues in there, so I missed some one or two questions, sir.
Okay.
Thank all the audience also for bearing with us. And if only there were any questions, we would have loved to answer, but if there are no questions, we'll stop here and good night.